I'm going to now introduce Professor Nick Pavlakis, who's our current chair of TOGA. Prof Pavlakis is known to many of you. He has an extensive research background into new drug development and biomarker research. TOGA's aspiration study is just one example of Nick's great impact in the field of thoracic oncology. We're very fortunate to hear him talk today about overcoming resistance in oncogene-driven non-small cell lung cancer. Thank you, Nick.
Thanks, Rachel. I think we should call it overcoming my nervousness following Solange in preparation. I thought I'd take the view of an overview of this topic because it's impossible to cover the area properly. And I'll show you, I think, at the end of this talk that we acknowledge more what the problem is as time has gone on, but we know still little about what the best strategy is in overcoming this topic. So Tom showed you this excellent diagram algorithm from Aaron Tan and Daniel Tan. The reason I'm showing it to you here is on the right-hand side. Most of our learnings of resistance have come from EGFR and ALK, but now you'll see that we have ROS1, NTRK, RET, BRAF, KRAS, MET, and HER2 emerging, and that we need to understand the nuances of resistance across all the different settings. But hopefully our learnings from some of the molecularly characterized subtypes of lung cancer can be applied in others. What do our clinical guidelines tell us about the way we should treat patients with an oncogene? This is from the ESMO Living Guidelines saying that if preferable, a first-line targeted therapy should be used when and if available. Since that Living Guideline, we've now had data for the EGFR exon 20 situation with amivantamab, and we have randomized phase 3 data developing with KRAS G12C and HER2 targeted therapy. Over 10 years ago, the medical literature was starting to get awash with papers describing the various forms of resistance that can occur, and these are illustrated here in this paper by Ross Camage. That could be pharmacologic, and this could explain some of the instances of resistance in the brain where we may not be getting enough drug in, but predominantly biologic, and they can be altered drug targets within the target, kinase domain mutations or acquired mutations, or bypass tracks. And not shown in the illustration is phenotypic change and also downstream signaling. This was a nice paper, again, published several years ago now by Alice Shaw's group discussing the evolutionary model of drug resistance. And I like it because it's a nice pictorial for what we think is going on. So there's two major hypotheses. The pre-existing clones model describes the likelihood that an innate tumour, the longer it's had a chance to establish, is heterogeneous, as Tom outlined earlier, and can coexist with a number of different subclones, be it P53, which we know is coffin expressed, and other kinase resistance mutations. You expose the cancer to a TKI, you get rid of the sensitive cells only for the other cells to emerge gradually over time. The persister evolution model is probably the explanation for the longer duration of responses that have small volume persistent disease, but who ultimately still develop resistance. The explanation there is that you can induce an acquired resistance through perpetual TKI exposure through changes, epigenetic exposures, TME and other factors. And the mixed model suggests a bit of both. And I was thinking of the answer to the question that Solange posted to Tom earlier as to would you want to give chemotherapy combined up front? And of course the same argument is when lorlatinib produced the CROWN data, should we switch to lorlatinib? I'll show you with lorlatinib as to why I think that makes sense because of the prevalence of kinase domain mutations. But in the EGFR setting, perhaps it is these other subclones that the chemotherapy is acting upon. What we don't know is that for an individual patient what the right treatment is to do. What we know in a randomized trial is that there's a population effect and that you're more likely to benefit if you have a particular combination therapy than single agent. But we are yet to find the predictive factor to decide what to do for an individual patient. This ELIOS study, a small translational study, demonstrates what some of the issues that we don't know. In this study, they showed that patients up front had high prevalence of P53 mutations, EGFR amplification, CDKN2A loss, and in fact, those common mutations, the more prevalent ones, remained at the time of progression. They also went on to look at the acquired mutations that can occur, and they're shown in the table here, some of which were targetable, such as MET amplification, EGFR C79S, and ALK fusions. Small pause here just to emphasise the importance of ctDNA, and I'm going to close on that as we introduce the next session as well. ctDNA gives us a window into the cancer in the patient as a whole, and it's not complete, but it certainly gives us perhaps more information on the spatial and temporal heterogeneity of the tumour in the whole patient as opposed to an isolated biopsy. And I'm going to show you some data that includes that. Tom showed us this earlier, and I don't want to reiterate the point except to say there is a difference if you look at the curves at the bar charts in terms of the unknown mechanisms of resistance in the FLAURA2 study when patients also had chemotherapy versus the osimertinib, and the frequency of the on-target effects seems to be less when you add chemotherapy, and the frequency of the off-target effects seems to be less when you add chemotherapy. But this is just a snapshot in one particular study, and I think we need to see more. So what do we do? This is the big question for patients with resistance. So there's the clinical situation of oligoprogression, whereby a solitary organ or a single metastasis, or 1 up to 3 or 4, can be managed with local therapy. That could also be considered in the brain, but the brain escape can be more challenging, for example, with multiple metastases or leptomeningeal disease. And in systemic progression, what we think we should be doing is looking at the specific type of resistance phenotype and then exposing the patient to therapy targeted towards that. Again, I know, Tom, you showed this diagram earlier today, just to briefly emphasise that there's a number of different therapeutic strategies that have been developed across the various spectra of systemic resistance that can occur. So the on-target mutations there, and highlighted there, are the various drugs that are now being developed, 4th generation TKIs, bispecific combination antibodies. The bypass tracks, we have MET targeting, we have RET, and we have other drugs that we can give simultaneously. Let's not forget histologic transformation, and that's something that probably is going to require a tissue biopsy in general to prove a squamous and small cell transformation. And what you think is the patient who has developed that may not be the case. I tended to think a small cell must be the more explosive, generalized population, but I experienced recently a case of a patient with an isolated adrenal metastasis that we resected. It turned out to have small cell in it, not EGFR. And then, of course, now we have the treatment of all comers, the empiric approach, the antibody-drug conjugates, the bispecific antibodies, and the combination therapies. This is a small study conducted out of China that looked at 104 patients with who had acquired BRAF alterations. They could have been BRAF fusions or mutations. And what they demonstrated here, and the purpose of showing this slide, is that patients who ended up having targeted therapy towards a BRAF actually did better. So the general principles to overcome resistance: at baseline, we can combine chemotherapy a la FLAURA2. We can look at adding bevacizumab, although we know that didn't result in overall survival benefit. We can look at using a bispecific antibody targeting, for example, a very common co-mutation or an acquired mutation such as MET, as in Mariposa. And when data comes into the space, perhaps integration of antibody-drug conjugates. In the resistance in the acquired setting, we could look at adding a drug based on the mechanism of action, and an example of that is what's done in the Savannah trial with adding savolitinib in the MET population. We can change chemotherapy or add different chemotherapy in histologic transformation. And when we don't know, or when there are multiple metastases, we can simply just look at an empiric approach. Some of this has already been brought to attention today, and I'll just focus very briefly. We have the combined approach, which has a survival benefit in Mariposa. Harmony 2, you just heard from Solange about the pitfalls of design, but it did show a strong signal for benefit with a bispecific antibody. And disappointingly also now in the empiric approach with HER3 ADC, we had the positive PFS signal with Herthena, but the negative overall survival result. ORCID's an interesting trial that we all have wanted to succeed, but I believe it's been challenging to accrue to, and it's intended to address this very question. If you can find the escape mechanism, then target it specifically. I bring it to attention just to show the ambition of the group in trying to do this, an international multi-center study. Some data was reported at ELCC this year on the use of Dato-DXd empirically in the group where we don't actually have defined, and that looks active, and I suspect that might be taken forward. Very briefly, I want to show you a real-world case that was one of the experiences. We design trials often by what we see in front of us, and this was one of the motivations for me, particularly with our Aspiration 2L. This was a GP who came to see me with EGFR exon 21 mutation, who went on first-line osimertinib. But I did do a ctDNA and found he had quite heterogeneous DNA expression. In retrospect, would I have given him combination therapy? Probably yes, but at the time, the data hadn't been published. So he had progression of disease at 8 months, so I gave him chemotherapy, including bevacizumab. He had an excellent metabolic response. He had persistence of EGFR in his ctDNA, but clearance of the other co-mutations, so he continued on osimertinib. 8 months later, however, he developed rapidly progressive liver metastases, and biopsy of the liver found an NTRK2 fusion. And throughout, I'd measured his ctDNA in the way that we intend to do in the Aspiration 2L study. So for illustration purposes here, you can see on the left-hand side the heterogeneity of expression of findings on his ctDNA, and on the right-hand side, his tissue biopsy with the liver metastases showing NTRK. And this patient had a short survival relative to what we've seen in the published literature, but quite a journey, only 20 months, but various treatments required along the way. And as I said, when you see a patient like this, you look back, what can I learn from the experience? He had a number of what we now know are negative prognostic factors that perhaps should have, would argue today to look at combined therapy up front. Now, let's not forget the situation of oligoprogression. Our radiation colleagues can still contribute significantly to the trajectory of systemic disease. Oligoprogression can be managed with the localized therapy. This was a nice phase 2 study reported at ASCO last year using SABR as a consolidative treatment in the vein of treating those persister cells, and it showed quite a long progression-free and overall survival relative to our benchmarking with Inflora, accepting the fact that it was a phase 2 trial and not a phase 3 trial. This was a study reported by a Chinese group that looked at radiotherapy to the primary and to the metastases in the local lymph nodes using 60 gray and 30 fractions, in addition to icotinib, which is their TKI, and it showed a progression-free survival, which was the primary outcome in favour of the routine administration of radiotherapy. And when I showed you those cells, those diagrams before, and you think about it, then you could probably try to infer why this may have been the case. A lot was studied about resistance following the first and second generation TKIs by the Boston group, and this was a nice publication that demonstrated the type of escape pathways seen, and at the time lorlatinib was emerging, and we knew it was a very active drug against many of these kinase domain mutations. But we've moved on. We now have alectinib or brigatinib, but generally around the world, and were the most commonly used drugs until the CROWN study, and now we have the CROWN study, which showed quite a marked and substantial and yet unmet progression-free survival median, and so a lot of us have shifted to lorlatinib. And one of the explanations, again, thinking back to that drawing I showed you with the coloured circles, is if there are multiple co-mutations and the escape pathways for which lorlatinib is active, then suppressing them for longer may be the explanation. But what I want to show you on the right-hand side is even lorlatinib can fail, and we have fourth-generation drugs that we're now looking at that we need to see. This is a study that we participated with Memorial Sloan Kettering. We took ctDNA in patients with advanced lung cancer in an observational study. We then looked at overall survival, top-level view, what was the survival for people who went on to get targeted therapy versus non-targeted, and in our joint population, we found a benefit substantially in those who got targeted therapy. We know that there are prognostic factors, but we lack predictive factors. So P53 in ALK, as it has been shown in EGFR, is also shown to be an adverse prognostic factor. The CROWN study reported its follow-up, and in that study they reported escape mechanisms to lorlatinib, and this was published by Ben last year. And what was interesting is that there were no new ALK resistance mutations detected in ctDNA on lorlatinib, and that bypass mechanism seemed to be the dominant mechanism of resistance in lorlatinib to the population at the time of publication. Only a small subset, of course, had actually progressed. There are a number of ALK-independent mechanisms, and many of us who've treated patients with ALK over a long period of time can attest to the fact that we do have isolated and unique escape mechanisms. On the right-hand side is our own data from the Octanate study, looking at the proportion of ALK kinase domain mutations we discovered in patients who'd failed a second-generation TKI who were alternating between lorlatinib and crizotinib. But these are the escape mechanisms here, the pie chart showing again P53 seems to dominate, but we had other things there such as MET amplification, ERB2 and EGFR amplification. But we're lucky we have new drugs. We have the ALK-1 study, the NVIL-655 study, which now is in phase 3, and this drug has shown activity in a refractory population and also in a lorlatinib-naive population. Does the same thing occur in other oncogenes? Well, I've always thought that ROS1 tends to be the closest relative to ALK, and this study, again, by the Boston group, highlights why that's similar, but not exactly, because if you look at the post-lorlatinib biopsies here, you'll see KRAS MET amplification, which we know occurs in ALK, but NRAS and MAP kinase as well, and then the ROS-independent mechanism, similar to ALK in terms of kinase domain mutations. In terms of KRAS, this is an evolving area. I've only produced a couple of slides here to show you what the literature is summarizing, what is going on in the literature. We do know that the mechanisms of escape can be varied. They can be at the receptor level. They can be in downstream signaling. We know with RAS patients, it's not exactly the same biology as the oncogene-driven ALK and EGFRs and ROS. We can get EMT transformation and we can get cellular differentiation. Mark Awad produced this paper of a series of patients who've been treated with adagrasib, and it shows you on the right-hand side the various bypass mechanisms of resistance that were reported in the 27 non-small cell lung cancer patients that he described in that particular study. And this schematic is just to reassure you that for everything we've uncovered, there's still lots of work going on in terms of drug development and different strategies according to the mechanism of resistance, whether that be at the receptor level up top, such as the addition of bevacizumab, EGFR targeted therapy, or other inhibitors. And then the open tables look at empiric approaches, chemotherapy, immunotherapy combinations, and other. So to conclude, first-line management of oncogene-driven lung cancer generally is preference towards targeting the target with a TKI. We don't know yet what's best in the KRAS G12C arena, and we have studies in progress in HER2. Resistance is definitely complex and heterogeneous, and we know the heterogeneity can occur at baseline and therefore can be innate, but it also can be acquired. Multiple strategies we've observed in development in the clinic, with a lot of our learnings coming from different situations, EGFR and ALK. Empiric approaches are in progress, but we're yet to see major successes yet, but I think we need to watch this space. Combination approaches that can be used and applied in the clinic include adding SBRT to the TKI, adding chemotherapy to the TKI, looking at other targeted drugs, such as adding a MET inhibitor or using a bispecific antibody. But understanding the mechanism of resistance to guide the therapy combination to a particular patient is the holy grail, and we hope we'll add some data to that in the Aspiration 2L study that you'll hear more about with Ben in a few minutes' time, and I think because you've also alluded to it earlier. So we'll be taking sequential samples on patients throughout their journey, not just at a fixed time point. What we have to work on really is what we're going to do at the bottom in terms of their therapies and record that data and see if we're making a difference. Thank you.